Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
A very good morning to all. The Hindu, in collaboration with Naruvi Hospitals, Vellore, welcomes you all to this Healthy India, Happy India initiative, under which we are doing a comprehensive 15-part webinar series to inspire and promote well-being and prevent illness. Today's session is the 7th in the series, and we aim to provide valuable insights into the role of iron in human health and what could be the consequences if there is either an iron deficiency or iron overload in the body. Iron, as we all know, is an essential mineral the body requires to keep it functioning. It makes hemoglobin. And hemoglobin is the protein in the red blood cells that help to carry oxygen throughout the body and thereby help us to live. But it is important to have that healthy balance of iron, as it should neither be in shortage nor in excess, because both conditions can impact our health. The right amount of iron is important for maintaining maternal health and the growth and development of children. It is also crucial for maintaining a healthy immune system to protect us from infections, and equally important for healthy muscles, bone marrow, and organ functioning. To guide us on preventing many conditions that are affected by less or more iron in the body and to be able to maintain good health, we have a panel of highly qualified doctors. And it is my pleasure to invite first the only male member in today's all-women team, as all our attendees can perhaps see on the screen. It is indeed an honor and privilege to welcome and introduce you Dr. Maman Chandy, recipient of the Padma Shri in 2019. The same year, he also received Dr. B.C. Roy Award. Dr. Chandy is currently the senior consultant, physician, and hematologist at Naruvi Hospitals, Vellore. He did his MBBS and MD in general medicine at the Christian Medical College, Vellore, and trained at the Westmed Centre in Sydney, Australia, where he obtained the FRACP and FRCPA degrees. He was a professor and head of hematology at CMC till his retirement in 2009. From 2010 to 2022, he was the director of the Tata Medical Centre in Kolkata. Dr. Chandy also received the CIBMTR, which is the Center for International Blood and Marrow Research. He received the Distinguished Service Award in 2014 for his contribution to the development of bone marrow transplantation in India. He will now introduce the subject with a general talk on the vital role that iron plays in our body. And also during the course of the program, he will also give the details to the National Nutritional Anemia Prophylaxis Program and suggest ways to enhance its effectiveness. So a very warm welcome to you, Dr. Chandy, and we are all eager to hear your talk.
Thank you, Soma, and thank you for this invitation. I want to thank my colleagues from Naruvi for having agreed to help us present this webinar to you, and also from Apollo Chennai, Dr. Revati and Dr. Ramya. Okay, so my brief in the next 7 minutes is to quickly tell you something about the role of iron in life itself. Now, all of you know that without iron and steel, life and movement as we know it today will not be possible. And iron is
Sorry, sir, are you sharing your screen, sir? Because we're not able to see the
Yes,
slides.
it's not sharing?
No, it's not. We can't see the slides. Maybe you could share it again.
Is that sharing now?
Yes, sir.
Yes, sir.
No,
Yes.
Okay.
Yes, please.
So, full screen mode. Okay. So, sorry for that. the role of iron in life itself, right? That's what I'm supposed to do in the first 7 minutes. And you all know that without iron, life and movement as we know it in the modern world would not be possible without steel, which comes as a product from iron ore. But in life systems itself, it would not be possible to have life without iron. In fact, if you see that cheetah moving at 80 kilometers per hour, it's doing so because there is iron, which provides hemoglobin, which provides oxygen for it to run. So also the runner you see sprinting to the finish over there. Iron is quantitatively the most important biocatalytic element in human enzymology. It has role in oxygen transport, in oxidative metabolism, and in cellular growth and proliferation. And this is because iron cycles between the ferric and ferrous form, and that's called the Fenton reaction. If we look at the role of iron at the level of individual cells, there are three important sets of proteins which are necessary for life itself. One is hemoglobin, two is myoglobin, and three is a set of enzymes, which I won't go into today. As Soma told you, without hemoglobin, we can't carry oxygen from the lung to the tissues. And this is possible because red blood cells contain a molecule called hemoglobin, which I'll come into in a minute. Similarly, our muscle has an iron-containing molecule called myoglobin, and that is how muscle is able to contract because it has myoglobin. And even at the cellular level, energy for the cell comes from ATP. And this comes from something called the cytochrome system, for which iron is an essential component. And this shows you the hemoglobin molecule. And if you see here, it's got a heme pocket and a little molecule of iron stuck in there. And without that iron, you won't have hemoglobin. And that is myoglobin. Now, iron is transported in our body by certain proteins, and the most important of this is a protein called transferrin. Now, this iron goes to the developing red cells in the bone marrow, and they have a receptor called the transferrin receptor. And iron can enter the red cell only if it's presented to it on transferrin. Ferritin is a storage form of iron, and there are iron regulatory proteins. This shows you in cartoon form how transferrin here has got a molecule of iron. It comes in onto the red cell membrane, enters the red cell, gives up its iron to mitochondria, where iron is synthesized within the into hemoglobin in the mitochondria. So it's a beautiful system by which hemoglobin is formed, controlled, and iron is an essential element there. Now, iron at the whole organism level is what we need to consider. And an average male has got 50 milligrams of iron in every kilogram of his body. A female has 40 milligrams of iron. And you can see that most of that iron is in hemoglobin, a little in myoglobin, and a tiny fraction in transport and enzymes, right? Storage iron is present in many of us, but if we are deficient, storage iron is absent. So this is the distribution of iron in the adult. Iron is taken in the diet, it's absorbed, it's transported to the erythroid cells, which use it to make hemoglobin, and that's the circulating mass of red blood cells, which contain most of our iron. It's stored in certain cells of the macrophage system. Then it comes back for recirculation, and it also is stored in the muscle. Any iron which is not required for hemoglobin enzymes or myoglobin gets stored in the liver as ferritin. Now, when we take iron in our diet, we are supposed to take 7 milligrams per 1,000 calories. Only 20 to 30% of iron presented in animal protein is absorbed, whereas iron present in non-animal protein, like in cereal, only 5% is absorbed. So the body has very limited mechanisms of excreting iron, and only 1% can be excreted. So an average adult male requires 1 milligram per day, whereas a female requires 1.5 milligram to make up for menstrual loss. Each baby requires 500 milligrams of iron for the total period of gestation. So mom has to take 2 milligrams of iron a day, get it absorbed. And as I said, only 10% of the iron in our diet is actually absorbed. And there's a beautiful mechanism in the intestine to regulate the absorption of iron, which you can see here. If there's too much iron in our body, the iron is stored in the epithelial cells of the intestine and lost in the stools. This is the repertoire of iron-containing foods. As you can see, many of them are animal protein related, but green leafy vegetables, I've sown broccoli, which most of us cannot afford to have, but in pulses and cereals and in spinach, there's a lot of iron. So it is possible to get enough iron for our daily requirement from the diet we consume if it's balanced and well laid out. Thank you.
Thank you, Dr. Chandy, for beautifully explaining to us the importance of iron in the body. Dr. Madhu Mitra is currently working as consultant in Department of Clinical Hematology in Naruvi Hospitals. She did her MBBS from Madurai Medical College in 2004 and followed it up with MD from Jawaharlal Institute of Post-Graduation and Medical Research. No, what is it called? JIPMA Pondicherry. DM in Clinical Hematology from CMC Vellore in 2021, where she also worked as assistant professor for the next 2 years. Dr. Madhumita's interests are in acute myeloid leukemia, myeloma, and benign hematology. She will give an overview of iron deficiency in adults, its causes, diagnosis, treatment, and management. Over to you, Dr. Madhumitra.
Thank you, ma'am. Am I audible?
Yes, yes.
Yeah. So at the outset, I would like to thank Naruvi Hospitals and the Hindu and Chandy sir for giving me an opportunity to directly address a highly prevalent health problem, that is iron deficiency in anemia in India. So iron in daily life, right from the cars we drive to the electrical appliances we operate and to the dumbbells we carry, iron has a major role both in vitro, that is outside the body, and also within the body. So in the next 10 to 12 minutes, I'll be throwing light on the causes of iron deficiency anemia, the clinical features, and the management. So why this topic? Because the prevalence of iron deficiency anemia when compared worldwide to India is 10 to 20% higher. So I can give you the estimates. The WHO estimate worldwide in 2019 shows anemia in women, that is in the reproductive age group women, was around 30%, whereas in India, it is around 53%. The prevalence of anemia in children, that is from 6 months to 6 years, is around 40% worldwide, whereas in India, it is around 53%. This is anemia in general. But across all age groups and all populations, iron deficiency anemia is the most common cause of anemia worldwide and also in India. So how much iron do I need? Roughly, as sir had already mentioned, about 8 to 18 milligrams of iron is needed per day. It differs between different age groups. The maximum iron requirements occurs during pregnancy, where roughly around 25 to 27 milligrams of iron is needed. But as Sir told, only 20 to 30% of the iron, roughly around 5 milligrams of iron absorption occurs in pregnancy, the maximum, which is maximum. And as we all know, there are two types of iron-rich foods. One is the heme iron and the other one is the non-heme iron. Heme iron usually is present in all the non-vegetarian diets, and non-heme iron is mainly in the plant-based foods. And heme iron is absorbed 2 to 3 times better when compared to the non-heme iron. Next, I'll be speaking about the causes of iron deficiency, which is broadly classified as nutritional, iron malabsorption, and secondary to blood loss. Coming to the nutritional part, either it can be because of a decreased dietary intake or because of increased physiological demands. So decreased dietary intake usually happens in strict vegetarians or who follow a vegan-based diet. And next, the diet is adequate, but still your demands, your body demands are much more when compared to your diet. This usually happens during infancy, during pregnancy, and lactation. Then the plate is full, your demands are all satisfied, but yet you have problems in your body in iron absorption, which usually happens in disorders of the stomach and the proximal intestine. So we'll be seeing what are all the causes in iron malabsorption. Then to save water, we should ideally close the tap and the leaky pipes and repair the leaky pipes. So we should always treat if there is any cause of bleeding. So this is another slide to stress the importance of the diet and as a cause of iron deficiency. Absorption problems, that is malabsorption in cases like H. pylori gastritis, which is quite common, autoimmune gastritis, because the acidic medium in the stomach, the HCl milieu, is important for iron absorption. And next, coming to the diseases of the proximal intestine, like the celiac disease, the inflammatory bowel disease, or hookworm infestations can cause absorption defects in iron. Then coming to the increased demands when cases of infancy, pregnancy, lactation, and we should also evaluate if there is blood loss, especially in GI lesions, reproductive female menorrhagia, repeated blood donations, etc. Next, we'll be concentrating, having seen what is the causes of iron deficiency anemia, next we'll be concentrating on the clinical features. So since the prevalence of anemia is quite rampant, almost like 40 to 50% in the women of reproductive age group and in children, we should be aware of the common symptoms which people in our house or ourselves will be having. So the most frequent symptoms are fatigue. Excessive fatigue. The patient will complain of excessive fatigue, no interest in her friends, family, or work, and there can be decreased exercise tolerance. That is, on doing exercise, the patient will have shortness of breath, he might have palpitations, etc. The other frequent complaints are pica, which means craving for non-food substances. The child or the adult may crave for paint cubes, ash, clay, or other non-food substances, and there are also chances for or increased craving for ice, which is called as pagophagia. On examining the tongue, there can be atrophic glossitis because for the papillae to function and to form, we need iron supplements. So in iron deficiency, the tongue will be bald and the patients will have atrophic glossitis, that is a bald, smooth tongue. So you recognize these signs as the public who's listening to this webinar. You need to take the people with the symptoms to a doctor, where the doctor usually sees for signs of iron deficiency anemia. You can see in the picture where you can see the doctor will examine the conjunctiva, which will be pale when compared to a normal person. The hands will be pale, and you can also see the nails, which will be either flat or it will be spoon-shaped. And as I already told you, the bald, smooth tongue. And in a person with iron deficiency anemia with dysphagia, we do come across rarely a condition called as Plummer-Wilson syndrome, where there can be esophageal webs in the cervical esophagus. And the next question is, do all patients with iron deficiency have a decrease in hemoglobin? It's not, because there are stages in iron deficiency anemia. Initially, the stores get depleted, which is called as a pre-latent iron deficiency, where the serum ferritin, that is the iron stores, gets decreased first. Then is a phase of latent iron deficiency, where the circulating iron protein is decreased. And the final stage is the manifestation as a decreased hemoglobin, where the hemoglobin decreases. Next, coming to the diagnosis of iron deficiency, the basic lab tests are a complete blood count and a ferritin. So coming to the complete blood count, you can see that the hemoglobin will be low, and there is some indices. These are called as red blood cell indices, which is called as MCV, MCH, which will be on the lower side in a iron deficiency anemia, and the WBC count will be normal. Sometimes there can be reactive increase in platelet count. So with this information, with the low MCV and MCH, we can, the next test which I would keep in my pipeline will be the ferritin. Ferritin is body's iron stores. By measuring the serum ferritin level, if it is less than 20 nanograms, we can diagnose iron deficiency anemia. There are some population, especially the elderly population, who can have anemia of chronic disease because of other heart failure or liver damage, where the ferritin will act as an acute phase reactance, and sometimes it can be falsely high. But more than 80% of the population, a person who's listening to this webinar, even in a remote setting, with the complete blood count and the ferritin, roughly both the tests, it will cost roughly around 1,000 rupees. CBC are 350 to 400, and ferritin around 600 rupees. With just a minimum of 1,000 rupees expenditure, you can diagnose iron deficiency anemia. And there are also specialized tests, which I'm not going to go through the details, but mainly the decreased hemoglobin, the decreased MCV, the increased RDW, and the decreased red blood cell count with a high TIBC, low serum iron and ferritin are the diagnostic picture of iron deficiency anemia. And but not the least, the bone marrow iron stores is the gold standard, but we hardly perform a bone marrow to diagnose iron deficiency. Most of the diagnosis is done with the bloods itself. So this is a peripheral smear showing the hyperchromic cells, and this is the bone marrow iron, which shows absence of iron stores. So having seen the signs, symptoms, the diagnosis, after confirming that it is iron deficiency anemia, we need to treat the patient. So always treat the primary cause, whether there is a malabsorption or there is a bleed, maybe GI or a PV bleed or a PR bleed, always treat the primary cause. Close the tap before you save water. And then you need to supplement the iron as per the requirements. So to look for primary bleeding, the BSG and the AGA, that is the gastroenterology guidelines, say bidirectional endoscopy. Both the upper and the lower gastrointestinal endoscopy should be performed in all men and postmenopausal women with iron deficiency anemia. Sometimes we do use screening tests like the stool occult blood, but that does not replace the endoscopy. In cases of other bleeds like menorrhagia, the patient needs to be treated with hormonal supplements or if surgery like a hysterectomy. After treating the primary cause, then we need to supplement iron. So the recommended daily dose of iron for adults will be roughly 100 to 200 milligram of elemental iron. It's not the full, it's not the weight of the chemical compound like the ferrous sulfate or the ferrous fumarate. You should always look into the elemental iron dosage, which is roughly 100 to 200 milligrams. Coming to oral iron supplements, the duration of treatment is usually 3 to 6 months, and up to 5 to 10% of people might have GI intolerance. Coming to the dosage, previously we were treating patients with iron deficiency with twice daily dosing, thrice daily dosing, but of late the studies have said that a single daily day dosing is more than sufficient to treat iron deficiency. And there are also multiple case reports saying alternate day iron supplements is helping in better iron absorption when compared to daily dosing. So coming to the oral versus the iron preparations, since we are also thinking about the cost-effective issues, oral preparations is the most effective preparation in most patients, especially the under-resourced setting, especially in a country like us. There is low risk of adverse events. There is low cost, but it needs to be given over a prolonged period, that is around 3 to 6 months. And patients might have some GI side effects. Coming to the IV preparation, whenever I need a rapid correction of anemia, for example, in pregnancy, a person who's going to deliver in the next 1 or 2 months, I will go for a IV preparation. Or if there is an ongoing bleed, ongoing menstrual bleed, or a PR bleed, I will go for a IV iron correction. The advantage is that we can give huge doses, like a depot preparations. We can give 1000 milligram, 750 to 1000 milligram depot preparations, and the dosing is also only 2 or 3 times. And especially patients who have iron malabsorption complaints, or patient who has undergone a gastric bypass, it will be better to go for IV preparation than oral, because the absorption is an issue here. But this requires specialized care, personnel and equipment, and patients need to be monitored for needs to be monitored for adverse reactions. So this is the list of the oral iron supplements. I'm not going into the detail. There is the good old ferric sulfate, and many of us have now switched on to the ferric fumarate, which contains almost like 50 to 100 milligrams of elemental iron. And there are no studies, head-on-head studies, which says that one iron preparation is better than the other. Then coming to the IV iron preparations, previously most of us were using the iron sucrose, which was given like 100 to 200 milligram dosing, 4 to 5 injections over a period of 2 weeks. But at present, if there is no financial issues, we can switch to ferric carboxy maltose, which is given at depot preparations of like 750 milligram weekly, 7 days apart, just 2 doses, and it's quite convenient for the patient. After having treated the primary cause, after having given the iron supplements to the patient, it's also better to supplement the patient with iron-rich food. We know that most of the non-vegetarian diets contain heme iron, which is better absorbed. Coming to the poor vegetarians, the best foods which has iron are the fortified cereals, which contains almost 16 milligram of iron per 100 milligram. You can take spinach, you can take lentils, you can take apricots, you can take cashews, oats, and broccoli. These are some of the iron-rich foods, especially for vegans. So we have given the treatment, we have given IV preparation or the oral preparation, and then we need to see whether the patient is responding or not. So the response to iron deficiency anemia treatment is by an increase in hemoglobin, which should be at least a minimum of 2 gram percentage in the next 3 weeks. And we usually look at the retic response. Retics are nothing but the precursors of the RBCs, which are pushed out from the bone marrow after starting hematinics. Usually the peak response is in the 4th to 6th day. We give oral iron, but still the patient is not responding. Then we can suspect iron absorption problems, where we do something called as an oral iron absorption test. It's quite an old test, but we do still practice. Adverse effects of iron preparations. Mostly patients have nausea, abdominal cramps, and constipation. For parenteral iron, the only important monitoring is for allergic reactions. If there is allergic reaction for one preparation, studies do say that we can switch to another IV preparation, and that preparation are mostly well tolerated. So the take-home message, please identify the causes, the symptoms of the patient. The doctor will look for the signs, go for the bloods, the simple blood test, give iron supplements. And I've not spoken anything about the blood transfusion. Suppose the patient has severe anemia, which we usually say less than 6 grams, but it's more about the symptoms. Suppose a patient presents with 2 or 3 hemoglobin, with the elevated JVP, with fetal edema, that is in failure, we have to go for a blood transfusion. Bring the hemoglobin to 6 grams, and then we can continue with either parenteral or oral iron supplements. Not the least, also supplement the diet with iron-rich foods. Thank you.
Thank you, Dr. Madhumitra, for the very detailed and long presentation. You overshot your time, I must say. And I was also wondering, why did you call the vegetarians poor? Anyway, and this is for the audience. We have 2 more speakers left, so could you please start posting your questions in the Q&A box, which is open now. We move on to our next speaker, Dr. Revati Raj, Senior Consultant and Pediatric Hematologist at Apollo Hospitals, Chennai. Holder of DCH, MRCP, and a Fellow of Royal College of Pathology, UK, Dr. Revati was trained there in pediatrics and hematology, oncology, and bone marrow transplantation till 2001. The subsequent year, she joined as a consultant in Apollo Hospitals, Chennai, where she now provides comprehensive and holistic care for children with cancer and hematological disorders. Dr. Revati's areas of interest include HSCT, or the bone marrow transplant for thalassemia, pelvic inflammatory diseases, childhood leukemia, and novel therapies such as the haploidentical hematopoietic stem cell transplantation. Dr. Revati will speak on the importance of iron, particularly in women and growing children, and throw light on how its deficiency can affect women and children in particular, and the right ways to fulfill the iron requirement for our body and its dietary sources. So over to you, Dr. Revati.
So thank you so much for the kind introduction, and to Dr. Maman Chandi and Naruvi and Hindu Health Wellness Series for this opportunity. I did mention to Dr. Maman that women and child health, especially related to anemia, is something that I'm passionate about. So I'm really happy to have this opportunity. We all know that we can see that someone looks healthy to say, do they look pink? Do they look pale? How does their skin look? How do the nails look? And I feel iron is the one thing that ties up all of this. How do we feel inside is all related to iron. So I'm glad you took up this topic because it's something that we should know about. So we all like stories. So the common types of people we see in our clinic. So I thought we'd through storytelling find out how do these patients present and how can we avoid being one of these. So a common scenario that we see is a teenager who decides that they are a bit on the chubby side and they have to go on a diet. So the diet does not include iron because when we are completely removing all carbohydrates, what are we doing for the iron? So they're not too bothered about anything else, but there is significant hair loss. So this is one of the side effects of iron deficiency, significant hair loss. So another young adult who started a new job away from the family is now staying in a hostel. Hostel food is not something she likes. So she's not been eating very well and the job is very busy. And 4 months into the job, there's extreme fatigue, unable to continue job because you're feeling so tired. Again, Dr. Maman already had said that extreme fatigue is one of the symptoms of iron deficiency anemia. So this is one of my favorites. The middle age group women who have to juggle a lot of things. So they have stuff to do at home, stuff to do at work, and there's a school teacher who's doing evening tuitions and has limited time for food intake. And the engine keeps running by the multiple cups of tea that she manages to take from morning till evening. And the husband actually brought her to my OP saying she's always irritable and she's easy to pick fights with. So there is a lot of irritability because of iron deficiency anemia. The other thing that Madhu also had alluded to, a 3-year-old baby who's been brought with an unusual eating habit. So the baby just loves to eat raw rice, chalk pieces. So this unusual food habit we call pica. So that's because iron causes a craving. It's almost like pregnancy for strange types of foods. The last and one story that I really worry about is up until 15, the child was doing really well. And these are all girl children that I'm talking about. And then now this year, the class 10 need to do better, but the school performance is declining. And when we speak to the child, she's got poor memory and unable to focus. She's attained menarche when she was about 13. Last 2 years, the periods have been heavy, and and she's on a pure vegetarian diet. So these are all things that have resulted in iron deficiency anemia. And then we see a child with recurrent mouth ulcers and recurrent infections. So iron is very important to fight infections and to keep our mouth healthy. So a child is not looking too weak or anything, because she's good at drinking milk and eats curd rice every day. So there's no, doesn't look thin or doesn't look ill, but there is mouth ulcers and frequent coughs and colds. So these are the common symptoms, and the common link for all of this is iron. And Madhu had spoken to us about how important it is to advise people about what to eat. And I can proudly say that I've been a vegetarian and I've been a blood donor all my life. So on a vegetarian diet, you can maintain provided you have a healthy balance of what you eat. So naturally, animal protein, iron is easily digested. And when we have vegetable source, the balance should be right. So I may be eating a lot of dates, but if I mix the date syrup with milk, the milk stops the iron getting digested. So if I'm having tea with all my meals, then the tea blocks the digestion of iron. So these are the sort of things that we see normally, especially during weaning period. The mother and grandmother are busy and the child gets a lot of feeding bottles. So milk intake after year one, more than half a liter per day, results in iron deficiency anemia in the toddlers, because it's easy to give them a bottle. So this is an article I really liked, because Dr. Maman's also going to highlight. We keep talking about iron deficiency. I do a community clinic at the Voluntary Health Services Hospital every Wednesday. And there are construction workers who are working at building sites, but their hemoglobin is 4 grams, 5 grams. And women are systematically, I feel, in our country, not fed properly. And the demands in a woman's body are far more because of monthly menstrual cycles, the pregnancy, delivery, a lot of things happening in physiology, which is not adequately addressed by our diet. It's an intractable problem, and we need innovative solutions, because right from young age, the girls have to be fed correctly, have iron supplementation, and if we have healthy young girls, then we have healthy young adults, and health, women's health during pregnancy, delivery is better, and they are going to feed their children better. So I think this whole chain can be set right if we address what we are feeding the girl children. And we see that the impact on the body is from head to foot, not just the hemoglobin, but the energy levels are low. It's linked to impaired bone health, and it's also linked to compromised reproductive function. So they can present to anyone, patients with iron deficiency, not eating enough, to a gastroenterologist, skin doesn't look right, is very dry, and hair loss, to dermatologists, or to a neurologist, saying that they have memory loss. So iron has a huge impact on the body, and not just in women, but also in children. And as Dr. Maman said, the newborn baby gets all the stores of iron from the mother. And the baby is a parasite. Whether the mother is iron deficient or not, they get enough. So if the baby is born premature, then they are more prone to iron deficiency anemia. And we have to focus on iron during the growth spurts. So during the toddler time, during the teenage time, and iron has a global impact on growing children. And not just the hemoglobin, but their immune system, their skeletal system, their heart, their nervous system. So it is something that we should address and make sure it's not just showing Popeye and say, see, Popeye is eating spinach, but it is for the well-being of the entire person. So I'll end by saying good health starts today, and I'm glad we have this webinar that can highlight what we can do to feed our children better, to have the young girls fed better, young adults better, and women of childbearing age, and the perimenopausal and menopausal women stronger for our country. Thank you.
Thank you, Dr. Revati, for the beautiful presentation and storytelling, the Iron Stories. We'll now quickly move on to our final speaker, and I would request Dr. Ramya Uppuluri, who is the consultant pediatric hematologist at Apollo Hospitals, Chennai, to speak on the body's challenges in eliminating excess iron and look at the causes and management of iron overload. Dr. Ramya.
Thank you, Ms. Soma, and a huge, huge thank you to the Hindu and to Dr. Maman Chandy for giving us this opportunity. And thank you, of course, to my mentor, Dr. Revati, for taking me along this journey today. We always think whether we should put our Sundays through another work-related thing. But truly, when it comes to iron, in our country, it's not work. It's actually a huge problem in the country. And if we are able to, in any way, contribute to increasing awareness and increasing knowledge among the public and among doctors about anything related to iron, it's truly time well spent. So thank you again for the opportunity. I'll talk a little bit about what happens with iron. As we said, we've gone through a lot about the health benefits of iron, but too much of iron also can have its own bad effects on several organs of the body. So again, let's consider a 4-year-old child, and we know children are very curious. We have tablets around in the hospital, in the house, and everything looks similar. And iron tablets can look similar to any other candy, which they may be attracted to. So a 4-year-old child has consumed a lot of iron tablets, thinking it looks like candy. Number of tablets not known. And this is something that we very commonly in our emergency postings in when we were doing pediatrics have seen. So iron can have its own toxic effects on the body. This now here I'm talking about acute toxicity of iron. I will come to chronic toxicity in the subsequent slides. Acute toxicity is a scenario like this, where by mistake excess iron has been consumed by the baby, most likely. Syrup iron also can be dangerous because sometimes the child may, you don't know, we know children can do anything. They may just and take the entire bottle in their mouth. So there are no symptoms. Usually, if they don't have symptoms for the first 6 hours, the toxicity may be limited. However, as we go along and as the dosage of the iron consumed has increased, the toxicity level can go up. Initially, they will usually come with vomiting. Further on, the toxic effects start coming on each part of the body, mostly because of what we call reactive oxygen species. So each organ of the body may get involved depending on the amount of iron that they've consumed. So a very important message, keep all medicines out of reach of children. And because they look very similar. Iron looks like this. Most iron tablets look like this. Popular candy also can look similar. And we know children can do anything at any time, even if 1 second we just take our attention out of them. So depending, as I mentioned, on how bad the overload has been or how much the child has consumed, in the initial stage, there may be just vomiting because of some gastrointestinal irritation. Then there may be, as I mentioned, because of the radioactive oxygen species, these metabolic acidosis, which can result in dehydration, lactic acidosis. There can be liver failure and a lot of GI mucosal bleeding and scarring. Again, not to get scared of taking oral iron. This is not the purpose of this presentation, is not to scare the public to say don't take iron supplements. This is a rare scenario, but can happen. So this is just a caution to say that be careful, especially with children in the house. When we keep iron tablets and other food, make sure that the medicines are kept in a cabinet somewhere which is unreachable to children. I have a 5-year-old. I know she finds ways of getting onto things. She'll take a chair, she'll take a stool, she'll put pillows on that to reach something which we say she cannot reach to. So we should be very careful when we have children in the house. So obviously, if we know that there has been a toxic consumption, we need to rush to the emergency. There are several medicines which I will come to, which can be given to treat the child. However, if they reach hepatic failure, etc., it can be quite a challenge, because then they need ICU and several other supportive care. Now I move on to the second scenario of iron overload. And again, I'd like to congratulate Naruvi Hospital and Hindu for this webinar, because this is, and I cannot miss an opportunity like this, which goes out straight to the public. The media is giving us this opportunity to talk to the public. So we cannot miss an opportunity like this to talk about thalassemia, which is a huge public health problem in India, and which is one of the biggest causes of iron overload in children. So this is a very common scenario. A 10-year-old baby girl, she's had chronic anemia for a long time. She's been taking iron supplements over iron supplements. Her HB has always been on the lower side. Many parents come to us like this, saying my child's HB is always 9. 1 year, 2 years of oral iron has been given to the baby, and there has been no difference. So this is a classic case where we see something called thalassemia trait. So if Dr. Madhumitra very nicely mentioned about the CBC, the blood reports when we look at iron deficiency. And she very importantly mentioned that the RBC, the red blood cell count, will be less. So between thalassemia trait and iron deficiency anemia, very similar picture you will find. The MCV, we say the volume of the size of the RBCs will be low in both. The RDW may be similar in both, but what is different is that because in iron deficiency, you don't have iron, you don't produce red blood cells, so your RBC count will be low. In thalassemia carrier, which is a condition where your iron is not the issue, your body just doesn't produce enough hemoglobin, your RBC count will be high. So this is a very important message for obstetricians, for gynecologists, for any physician, any doctor who is seeing children with children or adults, especially women who are registering for pregnancy. If you look at the simple CBC and you see that the woman is anemic, but the RBC count is normal as compared to the anemia, please test for possible thalassemia trait. And why this is important is what I'm coming to next. Thalassemia carriers, you can be a carrier, I can be a carrier. We'll have no symptom at all. We'll be walking, talking normal individuals. But the reason why this is important is because of this problem called thalassemia major. So thalassemia major is a huge public health problem in India, where it's a genetic problem. There is no red cell production. And these children need transfusion every single month of their entire living life to maintain a hemoglobin and to have normal life. So India is one of the biggest thalassemia capitals in the world. And, kudos to Mr. Amitabh Bachchan, who himself has said, I'm a thal carrier. And look at how he is. And that's a huge example for people to say that thal carriers can be normal. But what happens with a thal carrier is when two thal carriers decide to have children, both the partners are thalassemia carriers. As you can see in this, there's a 25% chance that their child can have thalassemia major. 75% chance they won't, but 25% chance that their child can have thalassemia major. And this is extremely important to sensitize the public about. So thalassemia is very prevalent in many parts of the world, especially where the environment is prone to have malaria. Africa, Middle East, India, of course, and several high-risk groups in India, which are Sindhis, Punjabis, Gujaratis, Bengalis, Saurashtrians. In Tamil Nadu, the Nilgiri area, the Dharmapuri, Sitteri areas. In every part of the country, we have this population which are endemic almost for thalassemia minor. I'm not saying major. They are carriers of thalassemia, but because we have a lot of consanguinity and we have a lot of marriages, even non-consanguineous, because of the prevalence of thal minor within our country, and because not everyone is sensitized to test for thal carrier status as yet, we have a lot of babies being born with thalassemia major. The children will be born normal at birth. After 6 months of age is when their anemia starts. They need a lot. As I mentioned, they need transfusion every month. So what happens when you get transfusions every month is your iron levels go up in the body, because every bag of blood has a lot of iron in it. When the iron levels goes up in the body, it can cause organ damage. And these children then need to be on chelators. There are 3 main chelators available in the market called deferoxamine, deferiprone, and deferasirox. Deferoxamine is IV or intravenous or subcutaneous. The other 2 are oral preparations. Of course, these have their own side effects. So these children have to be on these medicines lifelong with monitoring for their own side effects to decrease the effect of iron overload. Because the more iron in the body, the chronic effect of iron overload, it can, if it accumulates in the liver, it can cause problems in the liver. If it accumulates in the heart, it can cause heart failure. If it accumulates in the pancreas, these children can have diabetes. If it accumulates in the pituitary, which is a sort of a organ inside the brain, then they can have lots of hormonal issues. If it accumulates in the thyroid, they can have thyroid issues. So it can cause and growth, development, everything gets affected. So therefore, the main message to prevent thalassemia today, several societies in the country, like the Red Cross Society and Thalassemia Sickle Cell Anemia Societies, have come up with these beautiful pamphlets to say, when you're matching horoscopes, look for thal carrier state. When you're registering for pregnancy, look for thal carrier state. So that if you know you're a thal carrier, test your partner as well. And if both are thal carriers, this is what we need to do. Prenatal diagnosis, which means at 10 to 11 or 14 to 15 weeks of pregnancy, you check the fetus for possibility of thalassemia major. As I mentioned, 25% chance of the baby being, the fetus being affected. If unaffected, certainly proceed with the pregnancy. If it is affected, we don't have an option but to proceed with an MTP. So this is my last slide, and I'll end with this message that we need to work together. May 8th is World Thalassemia Day. The National Ministry also has recognized the problem of thalassemia, and along with the Indian Academy of Pediatrics, the PHO chapter, the Pediatric Hematology Oncology chapter, and several other groups have come up with more and more awareness programs, screening programs, health education for the public to be aware about thalassemia. And the last message is thal patients need blood transfusion. So everyone come ahead, be a blood donor. Dr. Revati mentioned she's a blood donor all her life, being a vegetarian. All of us, please come ahead. You can save a life by donating blood. And it is good for you as well because you produce more blood if you donate more blood. So I'll end with that, and thank you for your attention.
Thank you, Dr. Ramya, for your very information-packed presentation on this important aspect of thalassemia. We have already, I think, coming close to the end of the program, so I'll try to manage a question each for each of you from the audience. I'll quickly first come back to Dr. Revati, since you talked about blood donation. So this basic doubt about, as we understand, I don't think people really go for a hemoglobin test unless something really hits them. So if my hemoglobin is either low or high, should I donate blood?
So, when you go for a blood donation, there is minimum hemoglobin check. So, if you yourself are anemic, then you can't be a blood donor. So, we have a cutoff of about 12.5 for women and 13.5 for men. So, they will first check your hemoglobin, make sure you're okay before you could donate. And there are a lot, as we grow older, there is a condition called polycythemia where our hemoglobin is high, and in those people it is better to remove blood from their system, because if blood is too thick, that is also not good. But it is good to register as a blood donor when you're age 18 plus, because as you are a donor, you will eat healthy and you can save lives all through your adult life. Between 18 and 55, you can be a regular blood donor, and that has a good impact, positive impact on your health as well.
Dr. Baman, Suresh Pai wants to know whether iron tablets can act as supplement to increase the iron level. And if so, then for how many months should we take iron tablets? And what should be the dosage? So you have to unmute yourself.
So basically, if you're eating a normal diet and your hemoglobin is good, you don't need regular iron tablets. It's not necessary for you to take iron tablets. But we know that in India, 70% of preschool children and pregnant and lactating women are deficient in iron. So there was a national nutritional anemia prophylaxis program where we were supposed to give each woman one tablet a day for 100 days of the year. And that was meant to help the problem of iron deficiency in the population. So I would say that No, it's not necessary for a healthy person whose hemoglobin is normal to take an iron tablet every day. It's not required. If you're iron deficient, then you go to your doctor, and usually we give 3 months of iron supplementation to correct. If the problem persists, then you need investigation to find the cause.
Right. Dr. Ramya, people really don't realize that they are iron deficient. I remember a long time ago, Apollo Madurai, Dr. Rohini had conducted this anemia testing in the entire staff. And she said about 70% of her own staff were low on hemoglobin. So, why do you think, we are not really serious about getting a hemoglobin test? Is it because it's not an immediately life-threatening situation and it is kind of a chronic thing that develops? What needs to be done more, to make people come out and be more, uh,
No, you're
be
right.
able to?
It's sorry. So it's a chronic event. It's a chronic thing for your body, and I think it's more of apathy and more of, oh, I have other things. Ma'am, Dr. Revati, so nicely she told about those case scenarios which she's seeing, a 39 middle-aged women. I mean, you've got work, you've got 100 other things to do. Why would you think about yourself? And you have your children to take care of. You have to do this for your child, do this for your husband, do this for your father-in-law, do this for your mother-in-law. The whole thing. It's more of apathy, and it's more of I think ignoring the initial symptoms. Still it reaches a point where your hemoglobin is so low that you cannot do anything. The initial symptoms, as ma'am had already mentioned, simple things like fatigue, not able to focus on what you're doing, not able to do the activities that you usually used to do, is something that should tell us that probably go ahead and check your hemoglobin for possible iron deficiency. Also look at your lifestyle, because if you're overworking yourself, you're not eating at the right time, not eating adequately. Since I know that there are a lot of medical students as well, I think, who have joined, we all have gone through post graduation training in India, and we all know how grueling that can be. And a lot of medical students, when they do the first year especially of post graduation, I mean, the work is such, that is how it is. You learn as you work, but the work is a lot, so you tend to ignore yourself. A lot of us have had tuberculosis, a lot of us have had vitamin D deficiencies, a lot of us have had iron deficiencies. So I think, again, maybe in that population, again, to be more aware about your own health and focus on these early symptoms will help abate reaching a more severe form.
Yeah. I think Dr. Revati had mentioned in her talk about certain foods that should not be combined to stop the absorption of iron. I'll put this question to you, Dr. Madhu, from Aman, who's asking that how vitamin C rich food can help in absorption of iron. And there's another question on diet where somebody wants to know, or maybe you should reiterate the common sources of iron which are available in Indian homes.
So the vitamin C, usually the ascorbic acid, it creates a milieu such that the ferric form becomes the ferrous form, which is the most suitable form for iron absorption. So that's how vitamin C supplements given during iron supplements is able to enhance iron absorption. So that will be the answer for the first question. Coming to the second question, the iron-rich foods which we usually advise for people are like the groundnut cakes with jaggery, the dates, the apricots, spinach, and mainly if they are a non-vegetarian, the whole lot of fish, poultry, all the seafoods. They are all the iron supplements.
Can I
Uh,
add
yeah, yes, sir.
something
Sure,
that
sir. Sure.
in pulses and particularly millets, ragi,
Ragi.
these are cheap sources, and ragi as a porridge without taking out the outer coat. Please remember that cereals have iron, but most of the iron is in the outer coat. And when you polish rice very well to be really white, you've lost most of the iron that is present there, and the phytate in the cereal prevents whatever available iron from getting absorbed. So I would say that I agree that you don't really have to eat meat and liver and kidney and all that in order to get your iron source. You can get it from uh, simple things. You can get it from spinach, which is not expensive. Kire is available all the time in Tamil Nadu, and it's not expensive at all. 2, dates are not expensive. 3, if you take ragi, if you are able to take it as a porridge with jaggery, that's probably the fantastic way of getting adequate iron in a diet if you're not well off. So simple things can make a lot of difference.
So diet is the key important factor for maintaining our iron balance, sir.
Absolutely.
So Gagan Sharma is wanting to know, because we have talked about fatigue and the various symptoms that we see. So does iron have impact on our eye health and memory loss also in later years?
In fact, Revati mentioned this. There are beautiful studies in children which show that cognitive performance, doing well in school, all of that comes down when they are iron deficient. Work output comes down. In adults, if you take people who are tapping rubber and they're iron deficient, they tap half the amount of rubber as an iron deplete individual. So a nation's health and work output can depend on the fact that its population is not iron deficient.
Dr. Ramya Purushothaman wants to know, is there any gene therapy for thalassemia?
So the available curative and time-tested option for cure in thalassemia major is a hematopoietic stem cell transplantation or a bone marrow transplantation, BMT as it is known. So BMT is done in several centers now in country. Dr. Maman, their team, of course, was one of the first to do, and several others. Dr. Revati did one of the first unrelated transplants in the country, etc. So there are several, and now there are, I think, more than 100 odd transplant centers in the country. So BMT is readily available, even high-end, high-risk kind of bone marrow transplants. Many centers are doing. Gene therapy is under research. It's under study in several centers, probably in China and in the US. It hasn't come as standard of care yet. It's under trial, it's under research. If someone is interested in their child going through a gene therapy, they need to be under the trial in those centers to do the gene therapy. It is not readily available. Maybe in the future, yes, but at the moment, no. It's not easily available. Yeah, that's right.
Dr. Revati, there is a specific question for you from Aarti Rathore, who's asking, why do women have to take iron tablets during pregnancy now when it wasn't perhaps necessary in the past? Maybe she means her grandparents and all when they didn't take iron tablets. Why has it become important now?
Okay, so actually, very point on question, and thank you for asking that. Because when we want to reduce maternal mortality, the one thing that caused mortality is low hemoglobin. That wasn't actually recognized during my grandmother's era. So the number of women dying during childbirth was very high. So now we know just simple iron tablets that can be taken. I had already mentioned the baby needs a lot of iron, and the baby is going to take whatever iron the mother has and leaves the mother quite anemic due to iron deficiency. So supplements are very essential during pregnancy, and these false beliefs that if you take the tablets, your baby will become very dark, so don't avoid taking tablets, or it will cause gas trouble, so don't take the tablets. All these are wrong. Pregnant women must be encouraged to take their iron tablet, and as Madhu pointed out, to reduce the stomach side effects, we say take alternate day morning on empty stomach, and that one tablet will give enough iron for 48 hours.
So, Dr. Madhu, does iron tablets really give you constipation, and what should be done to avoid it? And also whether there are any allergic conditions for intake of iron?
The allergic conditions are mainly for the parenteral use of iron. The oral preparations does not usually give much of allergies. Constipation is known, with at least in 5 to 10% of the people do have constipation. The measure which is advised against this is that you can take oral iron supplements at least 2 hours before food or after 4 hours after meal. That is, in between meals is better. This can prevent some of the GI side effects. And coming to the other question, only the IV preparations can cause allergic reactions, not the oral preparations in general.
Dr. Mammon, how would a menopausal, post-menopausal, osteoporotic women, or I mean, basically senior women, how should they be managing their anemia?
In the postmenopausal period, uh, iron deficiency is not so much of a problem. Why? Periods have stopped. The iron loss, which occurs every month with menstruation, is gone. They're past the childbearing age, so that also is gone. And generally, in a higher socioeconomic group, food intake is okay. So I would say if a 55-year-old lady comes to me with iron deficiency, the most important thing is to exclude blood loss because of a malignancy. And therefore, getting the gastroenterologist checking out upper GI endoscopy and colonoscopy, as mentioned by Madhumitra, is probably the most vital thing. And sometimes you need to follow up. I had a 50-year-old teacher come to me with iron deficiency anemia. I sent her for a scan. She went to the gastroenterologist. She had a gastric ulcer. She was told, come back after 3 months for pre-biopsy. She came back 1 year later with tumors in the ovary, which was a gastric cancer which was missed and had spread to the ovary. So in an older postmenopausal woman, I won't say this is diet, I won't say this is okay. I would check out the cause and exclude GI malignancy. That's very important because you may pick up a GI malignancy with iron deficiency at a point where a curative resection can be done.
Somebody is asking whether cancer survivors are allowed to donate blood.
Generally, you have to be fit. And so most centers would say that if you had a previous cancer, you cannot donate blood. What could be another reason, which is very hypothetical, is we don't know what caused the cancer. It could have been a virus, it could have been something that could still be in your body. So, in general, I don't think blood banks will accept donors who are cancer survivors.
I think we're really short of time. I'll end with Dr. Madhumitra. One final question. Is there any ideal time to take iron tablets in the day? And also, another question is how many times or how frequently should people get checked for HB?
So coming to the first question, there are case reports saying that the acid secretion peaks at night. So for the with the acid milieu, it's better to take iron preparations in the night. But we don't routinely advise, but there are papers saying that. Coming to the second question, um, can you please remind me of the second question, ma'am?
How frequently should the hemoglobin test be done?
The hemoglobin, as we start with the iron preparations, usually we check the hemoglobin after 1 week. There should be at least some 0.7 to 1 gram increase in hemoglobin after 1 week of after taking oral iron supplements with good compliance. And once there is response after 1 week, if there is if the hemoglobin has achieved as expected, then we put the patient on oral supplements and then we ask them to follow after a month. And at 3 months, we usually check a serum ferritin. If the serum ferritin, that is the iron stores, if it has if the serum ferritin is also up to the mark, then we can stop iron supplements. First, the hemoglobin improves. So first, it's usually the first week. If the patient is, it is also depending on the hemoglobin value. If the patients have a HB of like 8, 9, I don't chase them. I give after 1 week, I check a HB, then after 1 month, then after 3 months, making sure that they have responded to whatever preparation I've given. If the hemoglobin is quite low, if suppose a patient has presented with a 3 or 4 hemoglobin, I will make sure I keep him or her on frequent visits, at least a couple of weeks, once in a week, early 1 to 2 weeks, and then a couple of weeks till the hemoglobin reaches 6 or 7. make sure that they are asymptomatic, and then I can keep them on monthly follow-ups.
And otherwise, for general healthy people who have no issues, that annual checkup they do once a year test is enough.
If there is no anemia, the once a year checkup is enough.
Right. So there are still lots and lots of more questions which remain to be answered, and I would request the doctors, you could perhaps directly reply to them. And I have to draw the curtains down because we've really overshot. I'm sure everybody found today's session very useful. Women who are natural caregivers, I feel it is also very important for them to know the requirement of iron, not only for themselves, but for all other members in the family as well, young or old, male or female. I thank each of you for joining today's webinar, and especially the doctors who spared their Sunday to educate us and make us more aware about iron's role in health and disease. Today's webinar was presented by The Hindu in collaboration with Naruvi Hospitals, Vellore, as part of Healthy India, Happy India initiative. Thank you all once again.
Thank you.
Thank you.
Thank you, Doctor.
Thank you.